Hello, everyone. I hope all of you can hear me. So, we start officially with our webinar. Good morning and good afternoon and good evening to all our participants joining from around the world. I would like to welcome all of you to this important webinar, which is organized by the Global Task Force of International Federation of Clinical Chemistry and International Society for Neonatal Screening on developing newborn screening in low middle income countries. So I'm Professor Aisha Habib Khan. I'm a chemical pathologist working at Al Khan University in Karachi, Pakistan, and I'm the co-chair of the Global Task Force of IFCC and ISNS. Briefly, I would like to tell you that newborn screening is a public health preventive strategy for identifying rare metabolic disorders, which, if diagnosed and treated early, can prevent developmental delays and mental retardation. But however, despite significant advancement in newborn screening globally, low middle income countries face unique challenges, such as because of infrastructure, finances, or training, which hinder the widespread implementation. So, in this regard, in 2021, IFCC and ISNS combined to establish this task force to facilitate countries in overcoming barriers through networking. And now in 2024, World Health Assembly has also accepted the role of appropriate newborn screening in such settings and provides the stimulus which is needed to offer screening for treatable conditions such as congenital hypothyroidism in all healthcare settings and sickle cell diseases wherever there is warranted. So this program today aims to explore solutions tailored to these regions, emphasizing approaches that leverage both traditional and novel methods for overcoming obstacles to newborn screening. And we have speakers, eminent speakers from IFCC and ISNS. So I would like first to invite our first speaker, Professor James Bonham, who is currently an advisor for the newborn screening blood spot program in the United Kingdom on behalf of Public Health England. He is also president of the International Society for Neonatal Screening. He has interest in organization, quality, and effectiveness of newborn screening and how this might be optimized and extended to benefit patients and families in UK and Europe, and now in low middle income countries, as part of the Task Force on Global Newborn Screening. He is recipient of many awards in this area, and he will talk about the potential for development of newborn screening in LMICs. Over to you, James.
Thank you for that, Aisha. And as Aisha said, we're going to talk this morning about the potential for the development of newborn screening in low and middle income countries. And indeed, we've got much to celebrate in newborn screening. 2023 marked 60 years since Bob Guthrie gave us a test for one condition, phenylketonuria. And since then, it's estimated that we've tested around 750 million babies. And for that single condition alone, we've identified around 60,000 children who can lead normal lives because of that early diagnosis and the treatment that the early diagnosis offered. And of course, putting that in context, that's a football stadium full of now adults, many of them, who can continue education, can go to university and lead successful lives because they've been treated early. So there's no doubt that newborn screening, where it's done well, has much to offer. Indeed, together, it's estimated now that each year around 500,000 babies benefit from this life-changing and important intervention. And that's led many around the world to describe newborn screening as one of the most important public health advances of the 20th century. So where are we now? Well, we've achieved much, and you can see that in some countries, newborn screening is very well embedded. In North America, it's screened for 35 core conditions and 26 secondary conditions, giving a total of 61 conditions in many states in the US. And similarly well embedded in Australasia and other places around the world. Perhaps a little more variability in Europe, where the number of conditions screened are spanned from 2 conditions in some countries to 48 in other countries. But perhaps some of the areas that really need attention, Africa stands out, and other low and middle income countries. So while we're doing well in screening for around 45 million babies now each year, that leaves 95 million without any form of newborn screening. And that's around about 2/3 of all babies born. Newborn screening has become a really topical issue, not just newborn screening in low and middle income countries, but with the advent of genomics, the development of newborn screening in developed countries. So how should we respond, particularly thinking about low and middle income countries? I think it's crucial that we work together. So while, as Aisha mentioned, IFCC and ISNS have initiatives in this area jointly, we're not the only ones working in this field. And it's hugely important to work together across a range of organizations to get the best result. I think it's particularly important to recognize that newborn screening is not just a laboratory test, but if we're going to be effective in delivering improved healthcare, then it's a pathway from the very time that the sample is taken through to transport, through to testing, and crucially, of course, into treatment for those babies that are identified as being at risk. And that means that we've got to have the availability of screening and well-organized screening, but also the availability of treatment. So how do we do well? Well, we do well by recognizing that more screening, the number of conditions screened, does not automatically mean better screening, but by being sure that well-organized and appropriate newborn screening can change lives. And perhaps there are no better two conditions to think of than sickle cell disease and congenital hypothyroidism. In Africa alone, we know that around about 300,000 babies are born with sickle cell disease in sub-Saharan Africa each year. And we know also that around 90,000 babies die from SCID each year in sub-Saharan Africa. And that's an enormous health toll. So work in that area is really pressing. Similarly, although we are testing for 45 million babies, largely for congenital hypothyroidism and other conditions, there are 95 million babies with that condition of congenital hypothyroidism that are not offered newborn screening. And assuming a prevalence of around about 1 in 3,000 amongst those, that means that we have 30,000 children born each year with congenital hypothyroidism that are not offered that important intervention. And we can see from the next slide that that really can change lives. Perhaps look at this. This is a particular slide with reference to the Philippines, and these children that you see on the right-hand side indeed are from Philippines, and the Philippines offers a huge encouragement for all low and middle income countries. But this family are worth looking at in some detail. That little boy on the right at the top of that slide on the right-hand side is 14. His sister at the time that that photograph was taken was 7. And their brother and sister, and the difference between the two of them is that that little boy was not recognized as having congenital hypothyroidism at birth, whereas the little girl was and was appropriately treated. And then if we scroll forward 14 years, then that little girl is turned into this beautiful young woman who's just completed her degree, I think in engineering, at 21 years of age, and is ready for a fulfilling life and hopefully a successful career. The little boy, who at the time was 14, is now 28 years old as a young man, and is seen there on the right-hand side in a wheelchair. And so I think we can see the huge potential impact for benefit for the individual, for the family, and for society of the implementation of well-organized and appropriate newborn screening, certainly for congenital hypothyroidism, and in some places for sickle cell disease, and also for many other disorders. And difficulty is not automatically a barrier if there's a will to do things. And I think that the Philippines exemplifies that really well. The Philippines faces special challenges. It's an archipelago of 7,600 islands with 110 different linguistic groups within that, and a population of 110 million and almost 2 million births per year. I'm told by Dr. Carmenchita Padilla, who's pioneered newborn screening in the Philippines, that I think uptake now is well over 90% for newborn screening. So despite these logistic difficulties and despite some resource limitation, there's been a huge success in the Philippines, where they now screen not just for congenital hypothyroidism, but for many inherited metabolic disorders as well. And you can see in the bottom bullet point there that they have effective and well-organized screening programs for 29 conditions. And they really are very well organized, looking at outcome, doing high-quality screening and coordinating that across a disparate group. So that's both an encouragement and a challenge to all of us in developed countries and in low and middle income countries, that this really can be done if there's people with a pioneering spirit to do it, strong patient advocacy, and crucially, as we'll see, governmental support and governmental involvement. So what are the obstacles that we must recognize? We know that there is much to achieve. What are the obstacles that we must recognize? Well, we do know that change is difficult to achieve. For instance, in congenital hypothyroidism, we've seen little advance in the last 10 years. Of course, that is to some extent colored by the fact that the population's grown, but a report 10 years ago suggested that the congenital hypothyroid screening was operative for 29.3% of children, and 10 years later, it appears it's now 29.6%. We've done well, but we should have been able to do rather better than that, and we need to work together to achieve that. I think we're living in a world in which external funding is difficult to obtain, and even if it is obtained, it doesn't lead to sustainable program development. These systems have got to be homegrown and home maintained. Treatment can be difficult to deliver and to source in some countries in particular, and it isn't a given that treatments, even relatively inexpensive treatments, will automatically be available. And I think there is a misconception among some health policy makers in low and middle income countries that these are expensive and sophisticated tests and something only for developed countries. And of course, that's not true. We know that the impact for families in a low and middle income setting of having a child with developmental delay can be really profound. And very often newborn screening for conditions like congenital hypothyroidism can avoid that. So what have we been doing about it? Well, ISNS has been working with IFCC, that's the International Society of Newborn Screening, working with the International Federation of Clinical Chemistry. And there's a great deal of enthusiasm within both of those organizations to see newborn screening spread and grow. And since 2021, we've been working together. One of the first things that we did was to put out a worldwide survey. We gained 426 responses from 84 countries. So overwhelming response, overwhelming interest in developing newborn screening. And some of those were for people from countries wishing to develop newborn screening, and others, thankfully, were from countries saying that they wish to help in the development of newborn screening. Interestingly, we thought that when we asked people what would help, it would be overwhelmingly about finance. And thankfully, to some extent, it wasn't. Of course, finance is important. But what people told us is that they wanted support both for education, for mentorship, for training, and for the involvement of clinical personnel that could bring expertise. And they also wanted input from laboratories that are experienced in newborn screening, could share that so that people wanting to develop newborn screening in more challenging settings could learn from that and hit the ground running. And that was really encouraging. And since then, since 2021, we followed up with contacts right around the world, and indeed had in-country visits to places like South Africa, Dominican Republic, Romania, Kazakhstan, and Bulgaria. And we've seen some successes, not success everywhere, and this is still work in progress in some places. But just as an example, following a visit to the Dominican Republic in last year, the Chambers of Deputies legislated in favour of making newborn screening available right throughout the Republic, the Dominican Republic. And of course, even there, it's one thing to pass a law and it's another thing to make this happen. And that's going on even as we speak. But as we've travelled around the world, enormous interest and enormous encouragement. So what have we learned so far? I think it's probably fair to say that there's unparalleled interest and a growing interest in the development of biochemical newborn screening in low and middle income countries. I think we can equally say that sometimes it can be frustrating. So what are the things that would lend themselves to success? Well, I think very often it starts off with passionate interest from local advocates and from patient groups. The patient voice is really important. And of course, we need people that are themselves patient, because this is hard work and it takes a long time to persuade health policymakers that this is an important intervention alongside competing healthcare priorities. I think it's really important to involve appropriate doctors, lab scientists, and policymakers working together in a team. And it really is that team effort that's important. And solutions need to be flexible, they need to be adaptable, and absolutely crucially, they need to be homegrown. This is not some expert coming in from elsewhere telling people what to do. But it's about encouragement, it's about mentorship, and ultimately it's about people taking control themselves within a low and middle income country environment. We've learned that legislation can be really helpful, but is not the end of the story. It's very often the beginning of the story. And it's about recognizing that newborn screening is a public health intervention. It's not, as we said before, just a laboratory test. And it's got to be planned and operated with a coherent pathway with that in mind. And perhaps one of the most important things for sustainable development of newborn screening is the active involvement of national public health policymakers. So if you're organizing a meeting, make sure that your health policy people are there. It will be a long journey to convince them that this is important, but because it is important, then you will eventually be successful with that. We had one particular encouragement last year, and that was a resolution brought forward by the World Health Organization to the World Health Assembly, which met in Geneva last year in June. And that suggested that because of the lessening burden of mortality and morbidity from communicable disease, they felt that the time had become right to advocate in favor of newborn screening in all healthcare settings. And that's a huge milestone for us, because that really does make a difference for governments in Africa and other places, because the World Health Organization is an organization with great integrity that governments really do listen to. So we're looking forward to seeing some of the fruit coming from that. What other current plans are there? Well, one of the things that we've been actively involved with is based upon a huge paper that Brad Thurrell, who's worked in this area for many, many years, produced recently. We've constructed not just a publication, that was a huge publication with 183 pages, as you can see there, and almost 2,000 references, well worth a read. But it's a long paper, but a very informative paper. But we've tried to turn that into a living and adapting virtual map where you can click on and see what's happening right around the world. And that's meant as both information, because information and evidence tends to produce change, but it's also meant as an encouragement for people to see what's happening in their locality, and for health policymakers to see how they compare with their near neighbours. So that virtual world map is now available and is hugely important. The next thing that we're doing, in fact, Indeed, we're starting this coming month in March in Luxembourg. We've created a newborn screening academy for those brand new to newborn screening, responding really to that call from that survey to look for education. And the first meeting, it's a one-day meeting, is going to be held in March. It is in Luxembourg. We recognise that that's difficult for many to get to, particularly from low and middle income countries. So we've also set aside some money for travel scholarships to attend that meeting. And we hope to do this as a rolling programme of academies. And of course, not all of them will necessarily be in Europe or the US. Some will. And hopefully we'd have scholarship support to help attendance, but others might be deeply embedded in low and middle income countries, and we look forward to doing that. We developed in 2021 alongside the task force International Neonatal Screening Day, which is celebrated each year on the 28th of June to celebrate Bob Guthrie's birthday. And we know that that has had significant impact around the world. And hopefully you see a web presence, a virtual presence celebrating that this year too in June. And indeed, we've got a planning meeting later today to look at that. We recognise, as I said at the start, that we can't do this in isolation. So we formed an international collaborative group, including WHO, American Society of Haematology, ourselves in ISNS and IFCC and others, to work together and to share information and to encourage one another. And this is leading inexorably to an increased number of publications in this area. And it is that evidence of peer-reviewed publication which is so important for health policy makers. And with that, I'm going to end and pass back for any questions and comments, and then on to the next talk. Thank you very much.
So thank you, Professor James, for such an enlightening presentation. And so I would request the attendees that if they have any questions, they should write in the chat, and we will take these questions towards the end of all the presentations. And I hope that some of the attendees should be able to go and attend the Newborn Academy that James talked about, and should also look at the ISNS website for the interactive map. And at the same time, I would also like to remind the audience that the World Rare Disease Day is tomorrow. And maybe, as James mentioned, that there's a strong need to develop newborn screening for rare disorders. So maybe, any one of you can have some motto for that day to celebrate as well. So now I would like to invite our second speaker, which is Dr. Hafsa Majid. Dr. Hafsa Majid is an assistant professor and head of chemical pathology and director of the newborn screening program at Aga Khan University in Karachi, Pakistan. She has played an instrumental role in establishing the newborn screening services at Aga Khan University Hospital Tertiary Campus and its secondary hospital, and also participated in introducing this screening for various IMDs. She is an accomplished researcher. Dr. Majid has published extensively and secured multiple grants, aiming to advance IMD diagnostics and education. And with a vision for collaborative research and policy change, she is dedicated to elevating early detection and treatment in pediatric healthcare. She will talk about the training of dried blood spot collection using a virtual learning environment. Over to you, Dr. Hafsa.
Thank you, Dr. Aisha. So, hello everyone. I'm Dr. Hafsa, and today I'll be taking you through our journey of developing a virtual learning environment, a course for virtual training of dried blood spot specimen collection. So, I have nothing to disclose. So as Dr. James has already mentioned, that the goal of the newborn screening is to identify individuals, infants who have treatable disorders before developing symptoms. And these symptoms, they are not present in birth. And the most of the neonatal deaths are in the low and middle income countries, as you can see here, that nearly 70% of the deaths are neonatal deaths are in the low middle income countries, mainly Africa and the Southeast Asia. And a major cause of these neonatal deaths is congenital disorders, which can be picked on the newborn screening. So this is particularly vital, essential for LMICs to introduce the newborn screening, also because they have higher birth rates and higher prevalence of these treatable disorders, and which, if left undiagnosed, can lead to higher mortalities in these are leading to higher mortalities in these regions. But despite this need, many LMICs have been shown to adopt very slow in adopting or not adopting the newborn screening programs entirely. So this table on the right shows that nearly only 10 countries are responsible for the total 70% of the neonatal deaths. And of these 10 countries, 9 are low middle income countries, and Pakistan and India combined, they have a total global prevalence or percentage of neonatal deaths of more than 30%, so around 40%. So which shows again that which areas we need to focus. So we need to focus the Southeast Asia and also African countries. And we know from the literature that the common diseases which are which are the leading causes of neonatal deaths are infectious, but followed by the congenital disorders. And we know that few of the congenital disorders, they may have very non-specific symptoms, can present just like sepsis, pneumonia, or asphyxia. So it's essential that newborn screening is implemented in especially the LMICs, to control their neonatal deaths. So the preferred sample collected for newborn screening testing is a dried blood spot. Because of its simplicity of collection, it's minimally invasive, it's less traumatic for the babies, and it has handling of these samples as compared to the venous samples is easy. It has less onerous storage and transport requirements. It can be used for multiple tests. You can do multiple tests from a single dried blood spot card. So it has it is significantly cost effective as compared to the venous specimen, and also it's ideal for the home collection. So this sample has became the sample of choice for many of the analytes, not just for many of the disorders screening and monitoring, not just the newborn screening. It's also now increasingly being used in the toxicology labs, in the therapeutic drug monitoring, and in another diagnostics and research setting as well. So it's now being commonly used in field as for screening the population for infectious diseases. But the limitation is that the target analyte concentrations in these DBSS specimens is very low. So although it is necessary to have very sensitive assays with very low analytical sensitivity, but also necessary to have a very high quality dried blood spot specimen, so that you are able to extract the analyte you are analyzing. So this paper here shows how improper collection can and specimen storage conditions can lead to the changes in the target analytes concentration. So on the right, the figure on the right shows that the most affected amino acids, so there are multiple amino acids and the biomarkers, acyl carnitines and other markers which are affected. This paper only analyzed the effect of the storage on the 4 amino acids, so which I am showing here. So they showed that the methionine especially was very affected by the temperature changes during the storage. So with increased storage at the ambient temperatures, it led to reduction in the methionine levels over time. The figure on the left shows that how the relationship between the sample volume collected and the size of the blood spot. As you can see, the low sample collected size is small. But why are we showing it here? Because it affects the concentration of the analytes. On the right, the figure shows that if the sample is collected, there's minimal effect if the sample is collected from either the periphery of the specimen, of the DBS, or of the center. But if you collect a subpuncture from a blood spot which has low volume of blood, it will lead to it will affect the concentration of the analyte of interest in your sample. So as you can see on the very right, when the samples were collected from the 25 microliter blood containing spots, the concentrations, both when the sample was collected, puncture was done from the center of the spot or from the periphery, they were both affected. They were both low. And also the hematocrit, the amount of hematocrit in the specimen, it leads to changes in the concentration of the analyte. So dyed blood spot specimens with low, so usually how do you identify the low hematocrit spots? They are more smooth. They have smooth edges, like you can see in the left figure, when the 35% hematocrit was present in the specimen. Sorry, the edges were smooth while edges were rough, and the circle is smaller and darker when the hematocrit is higher. So why is hematocrit important? Because concentration of the biomarkers which we analyze for the newborn screening, like amino acids, the acyl carnitine, the succinylacetone, it is affected by the hematocrit value. So when this study also analyzed the difference in the concentration of the target analytes when the specimen had a hematocrit of 60% and hematocrit of 30%. So what they found was that amino acid concentrations can be higher. It can be higher by 27% in samples with higher hematocrit values. And similar bias was noted in the acyl carnitines and succinylacetone levels. So that is why this relationship, it shows that the DBS size and hematocrit has a significant effect on the quantification of your biomarker of target biomarker. So this shows that the person collecting must understand what is an appropriate, a good quality specimen, and how a low quality and how a good quality specimen can become a low quality specimen during specimen handling and transport. So these these issues do not affect the quality of the analysis or results of the patient. So usually in inpatient settings, the samples are connected by the nurses and allied health professionals, which are normally trained on site for the specimen collection and evaluated before being independently before they start independently collecting the samples. While in outreach or field, it's collected by the community health visitors and by non-healthcare personnel who could be the parents, patients, or in research settings, it could be research assistants and associates. So to avoid the before mentioned issues, Both the healthcare as well as non-healthcare personnel should receive regular trainings on DBS collection techniques to ensure that more accurate and less variable results are obtained on the analysis. What is the most commonly used method is the synchronous method of training, like on-site training, which is given by a trainer to the trainees while the trainees are present on-site. But there are different challenges. These trainings, they require dedicated faculty, facilitated time, which can sometimes be challenging considering the clinical and academic responsibilities of the facilitator. Then there is need to conduct repeated sessions for the new recruits due to staff turnover, for the old personnel, for refreshers for the old personnel, which again adds to the workload. Then also there is limited capacity of synchronous setting. So synchronous setting, you cannot accommodate a very big group of 50, 60 persons at a time. You have to do it in small groups. So there is a limitation. You have to restrict the number of trainees that can be accommodated at a time. Also, when there is variability in the in the trainers, it can lead to variability in the training in different sessions or different sites, which can produce procedural, which will then impact the procedural consistencies. And with the alignment of local and international standards, it's and to ensuring that the every session is aligned with your own local and international standards is difficult. While the advantages which are of the virtual learning environments are that they are more interactive, they are scalable. You can you can train multiples at one time, multiple trainees at one time. And they are not just the one directional training sessions. You can make them interactive by introducing the interactive quizzes tools. And also this offers flexibility to the trainees who can do it at their own pace at their own time. This also reduces the scheduling conflicts which can arise during the synchronous sessions, that you have to be there on this time on this day. Also, it's accessible to everyone, so you can even reach the far reached areas, you can reach the unreached through these virtual sessions. The training will be standardized. It will not be affected if the training is done at one site or two sites by one operator or two operator, because this training content, the training assessment tools, they are all standardized and they are all aligned with the international standards and your local standards. So the training is more standardized and comprehensive, and also it's self-assessment, so it reinforces the learning. So keeping all this in mind, we plan to develop a virtual training course on a virtual learning environment Moodle to train the healthcare. It was basically for the healthcare professionals, but it can be used for the non-healthcare personnel as well for the DBS specimen collection. And our aim was to determine the acceptability by the trainees and feasibility of this virtual learning environment as a tool for DBS specimen collection. This was a cross-sectional study done at the Ahmad University, and 4 hospitals were included in this study. This project was initially approved by the Institutional Ethical Review Board. Project team included all the relevant personnel and the nurses, and the phlebotomists and ICU technicians were initially trained in this project. So moving on to the online module development, which was developed on the Moodle. We first developed a contextual curriculum based on the CLSI and guidelines and the College of American Pathologists standards. The content included the instructional materials, the reading material, the videos, the flyers, the flashcards, a presentation on the on our own hospital's program, what we are doing, how we are doing it, what will be the our policies, our collection sites, everything related to the procedure, about the specimen, what is considered a good specimen, frequency of training, and how a refresh, how this whole process is monitored, and when will a trainee be needed to undergo a refresher training. This was followed by a knowledge assessment for which a quiz was created. Initially, the passing criteria was 100%, which was then reduced to 80%. Then the trainees, for the on-site session, the trainers were performing a demonstration, which was followed by the performance by the trainees, and direct observation and competence checklist was filled by the trainers. While in this, the online module, the demonstration was replaced by the videos, and the form was filled by the trainers after direct observation. And one of the prerequisite of competence assessment was that you have to have cleared the your knowledge assessment part. So, okay, and to ensure the content validity, two non-team members, so two members who were outside of our project team piloted this module, as well as reviewed all the content, and our objective was just to assess the difficulty, reliability, and accuracy of both the quizzes and study material. The indicator which was monitored for the two types of, to compare the two types of training methods, was the number of unacceptable samples received for 6 months period after the on-site training, and simultaneously after the virtual training. So on-site training was done at one hospital, while the virtual training was done at 3 hospitals. So there were 3 sessions conducted at the Stadium Road campus only by the chemical pathologist and a biochemical genetics scientist, which included all the instructions, followed by demonstration and direct observation, and competence checklist was filled by the trainees. While in online session, we use a train the trainer approach. So the hospitals selected were not just in one city. So what was done was a trainer was selected from each hospital. At least 2 trainers were selected from each hospital, and they were then they traveled to the Stadium Road campus, where the trainers training and direct observation was done. Then these trainers were made a teacher in the course, and they can then enroll the trainees at their own hospitals for the training. The trainees were then requested to, after enrolling the trainees, were then requested to complete the educational component, read all the things, view all the videos and everything, complete your quiz. Once you have achieved the desired score in the quiz, they were then asked to collect the specimen on a newborn. So they were directly collecting the specimen on the newborn, and the trainer was then assessing and filling that checklist, which was also available on the virtual learning environment. And at the end, a certificate was generated, which was downloadable and can be saved in the NERS or the AHP's file. So what we found was that the number of trainers, the number of trainees we were able to train. So during the so the on-site training was done for 1 year, while the virtual training was done, the period for virtual training, which was assessed, was only 6 months. So we were able to train more persons during 6 months compared to the 1 year where we did the on-site trainings. The cost of training was high for the virtual training, but this is the initial cost, which is high. Once the module is developed, because the e-learning developers were engaged in developing this course, so this is the one-time cost. So this cost will not increase if the number of trainees trained increases from 104 to 1004. But the on-site session cost, it will double once you double the number of trainees. So first, the initial investment is higher in the virtual, but it has long-term benefits. Instructor engagement was also found to be more in the uh, in the virtual module. Initially, the engagement was due to the course development. The course content was developed by the facilitator, and the forms and the checklist and the quiz, everything was developed. So all that is one time investment only. It's one time engagement only. So that will not increase when the number of trainees increase. So and also the when you look at the indicator, which was the unacceptable samples, you'll see that the unacceptable samples reduced after the virtual training. So we found that the virtual training was effective for training the personnel to collect TBS specimen. One of the challenge mentioned by everyone was that the trainees had to collect sample on the newborns directly. There were no dummies and simulators. Hence, this is an ongoing project. We then went on to develop a heel prick simulator for our trainees. So to address this challenge, we plan to develop an in-house heel prick simulator. And in initial discussion, because the training was not just in one city, it was done across Pakistan. There were no hands-on dummies available. There were only visuals, or the trainees had to collect directly on the newborns. So after brainstorming, reviewing multiple papers, we developed multiple prototypes. There were multiple attempts. This is still an ongoing project. We are now on to our a prototype which we can on which we can comfortably train by 10 up to 10 trainees can be assessed on one prototype. So this is still work in progress. Our plan is to make a multiple simulators like this, which can then be sent to different cities, to the trainers in different cities in the different regions, who can then use it instead of telling trainees to collect samples directly on the babies. So to conclude my presentation, the dried blood specimen collection is now widely used, not just for the newborn screening, but in many diagnostics and monitoring procedures. And as already mentioned, that these samples in many cases can be collected by the patients or the parents themselves. And sometimes they're even transported across the continents for analysis. So there may come a time in the future that when a parent wants his baby, or a patient wants to get tested for let's say genetic test, they will request for a kit, a DBS specimen collection kit, which will be sent to them, and they can then collect they along with the educational material. They'll see the educational material, collect their samples, send the samples back. So the time is almost there that we will be transporting these samples across continent for the analysis. And these virtual learning based training modules can be helpful in improving the quality of those samples. They help in standardizing the procedures, enhancing the ensuring that the samples are of good quality and patient gets the reliable results. So also the virtual learning based training and the heat prick simulator prototype developed, it offers scalability and flexibility of training, enabling you to train a large number of students, minimizing your logistic constraints and the trainer involvement. Thank you.
Okay. Thank you, Hafsa. Thank you for an excellent presentation and excellent work. I hope it will go a long way in developing and training DBS training of the sample collection. So all questions addressed to Dr. Hafsa can be put in the chat box, and we will take these questions towards the end of the presentation. And now I would like to introduce you all to our third speaker, Dr. Leena Jaffrey. Dr. Jaffrey has served as Associate Professor of Chemical Pathology at Al Khan University and as the Director of Point of Care Testing Program. She is an esteemed educator, a FAMA Fellow, and Fellow of Higher Education Academy UK. And she has played a pivotal role in advancing pediatric healthcare in Pakistan by implementing the newborn screening program for IMDs at AKUH. She successfully established a community of practice across Pakistan by the name of Pak IMD Net, a group which is focused on enhancing trainings and fostering collaboration among healthcare professionals, researchers, policymakers on IMDs in Pakistan. So over to you, Leena, and you have 20 minutes for your presentation.
Okay, Dr. Aisha. Thank you very much for the kind introduction. So good to see you after a long time. So basically, I will take you through the journey of good day, everyone, and thank you for joining in. I will take you through the journey of our expansion of newborn screening in Pakistan, specifically in a
Leena,
small.
your camera is off. Switch on your camera.
Can you see me now?
Yes, yes. Okay.
Okay. So I will take you through the journey of expansion of newborn screening, how we started from one blood spot and then shifted to one blood spot, one disorder to more than 12 disorders now. So these are nothing but images capturing moments from World Rare Disease Day in the past that we've been celebrating since many years. And these are moments of resilience, moments of advocacy, and moments of hope for rare disorders. I have nothing to declare and no conflict of interest. So, my journey and my story is from a center which is located in the city Karachi. It is a metropolitan city in Pakistan. And this city and this center, specifically Ahan, is very different because it has been taken, has been at the forefront of newborn screening, specifically implementing it when there is no national newborn screening program in the country, and the national policy for newborn screening has not been implemented. So, like James said, here we do have people with the pioneering spirit, I would say. Thank you for that word. So I would like you to go through the roadmap so that you know and you are with me for the next 10-15 minutes, that where we will be by the end of of my presentation. So we started, it was a phasic approach, taking it from how congenital we scaled up to congenital adrenal hyperplasia and then took a big leap to inherited metabolic disorders, covering education, how selection was done, and technical aspects of the metabolites were taken care of. So let's revisit. We've been discussing what newborn screening is, but quickly let's revisit so that all of you are with me that newborn screening, what is newborn screening? It is an established way to identify babies for serious disorders that are treatable but not apparent at birth. It is a standard of care, and like James said, it is a pathway. It is a system and is strongly recommended for all babies at birth. So this might look like a busy slide, but what I want you to do is I would like to encourage you to focus on one key takeaway. What? The immense amount of hard work that has gone into make this progress possible. So if you look at three important years, I would say 2019 was when we introduced congenital hypothyroidism screening at the main campus of our Khan University in Karachi, and then we moved to congenital adrenal hyperplasia in 2021, and then learning from these experiences, and meanwhile educating and training our technical people, and also getting the critical instruments procured. We took a big leap of involving or adding inherited metabolic disorder only in 2023. I will not go through the details, but this basically shows that the amount of work that has gone through and how we learned from each disorder and then added IMDs based on certain reasons. So let me quickly discuss a little about how we expanded and how we added these IMDs in the list of newborn screening from endocrinopathies to the inherited metabolic disorder. Because of, of course, certain reasons, I cannot disclose everything, but we started with gap analysis and we brought to the table the need for the resources and the need for training, which was the biggest concern as section head then, and as one of the biggest concern was the resources that we did not have. So you can see that this included instruments, training, and how even faculty and technologist training was as important as anything could be. And then we identified what we needed for we did a horizon scanning, okay, what could go wrong and what could be the bottleneck for expanding and adding inherited metabolic disorder. Of course, as pathologists, we were the lead, but we also had other departments like OBGYN and pediatrics of always with us, and these discussions were in line with them, and these were something which were not hidden from the leadership. From time to time, Dr. Aisha is here, and I would like to say that under the visionary leadership of few of the people like her who laid the foundation for newborn screening of congenital hypothyroidism, we moved on and kept on discussing and asking for resources and ran financial feasibility many times to convince the leadership. Then we, of course, once we had the right instrument, the right training, we started with the optimization, which was the biggest challenge that we could see. And we started off with analytical and clinical validation. I will not go into the detail, but many of the people who have registered here and have connected are from the laboratory, I know. So you should know that specimen are the prime, the correct specimen is the basic foundation for any analytical validation. So DBS samples from a newborn cohort was very easy. That was something which we could, but known values for clinical validation, for analytical validation, was the biggest hindrance, because these IMDs are very rare and we did not have those dry blood spot samples available anywhere in Pakistan. So using my contacts at Mayo, where I had gone for my training for 3 months in Mayo Clinical Lab, I used, and they were my contacts, and they were very kind enough to send me like birthday cards. I was posted the DBS cards with known values, and we took those cards to validate our analytes, and also we took help from CDC specimens to validate our assay. So this was done on LCMS, MS, tandem mass spectrometry, and these were the markers. I will not go into the detail, but they were amino acids, succinyl acetone, and a long list of acyl carnitines that we successfully validated. I would like to take Azima Jamil's name, who was with me hand in hand in the training. Also, she also went to Mayo and in getting these done. So we also collected clinical data for validation, and the studies conducted were the same that we usually do in lab. Sorry, next. So the whole process from LCMS, MS procurement to in-house trainings, and remember that COVID had hit during this time. So we were going through a tough time, the lab. So, resources were an issue and we had to, fight for this. But we were lucky enough that there were so many pro, I would say, newborn screening. Like COVID, if you put the word COVID, everything would get approved. So newborn screening, these were the times when it was easy to get things approved then. So we got approval for in-house trainings, and the vendors were also very supportive. And then of course external trainings were there. Then besides that, once validation was done, the biggest challenge was selection of the right IMDs, because we had a long list of acylcarnitine, amino acid, succinyl, acetone, and we could pick up more than 30 disorders, but there were certain things that we had to take care of. I will discuss that those things just in my next slides. But it was very important to understand that this was teamwork. So me and my colleagues in the clinical lab, we invited our pediatrics colleague, and we sat down to review the clinical screening algorithms, and we developed them together. So this way, they have the ownership of the algorithm, and they know when to communicate, who to communicate. And even my people from the laboratory know when and whom to communicate at the right time. So it's very important to keep everyone on board and keep educating the lab technologists about the processes and the program, and also keep educating the neonatologists and people who will look after these babies once you get a positive result. Then, of course, we had different CMEs and multiple sessions. I went to the department, me and Hafsa, and had multiple education sessions. We took care of lots of, question answers, cost included. I will not touch upon that. But of course, you need to understand their concerns. And as a laboratory person, we were successful in, convincing them. Then also, we did have proficiency testing provision. So that also gave us confidence in the in implementing or starting newborn screening for the babies born at our Khan. So this is just a single center story that I'm telling you. This slide I will not touch upon, but I would like to show you that how I have used chat gpt. I gave the information to chat gpt, and this is what a colorful slide that chat gpt developed for me. This is basically, I do have issues here, but what I'm trying to tell you here is that a lot of hard work and a lot of discussions. What you see in the front is a table that this was not just done by me or my colleagues in the lab. This included people from nursing, people from OBGYN, people from pediatrics, and even from the leadership. So it was a joint successful project. So how we selected the disorders for implementing newborn screening in Pakistan was based on the population frequency. These are the principles of newborn screening published by Wilson and Jugner years ago. And so we took care of the population frequency, national history history of every disease were looked upon, and how the availability of screening tests, availability of confirmatory tests, and how it would impact the baby and the parents. What was it, treatable, manageable, cost effective or not? So every disorder that we discussed was discussed based on these principles. And these were the final markers that we as team from all the three departments agreed upon, mainly pediatrics and the laboratory, of course, chemical pathologists. But these were the 9 markers that we decided upon based on the principles. And these algorithms, like I discussed, I cannot show you all because of the time constraints, but these were developed jointly and disseminated multidisciplinary. Like it is available on the intranet of our Khan University, and any clinician, whoever has wants to review it, can review it. It's easily accessible, and all of the involved people with newborn screening are adequately trained to use these or follow these algorithms for screening. So communication, again, I would like to reiterate that communication in newborn screening is very important, and you should have clear reporting pathways, and the patients and the babies and their parents should not be left alone. Even the clinicians sometimes need help and guidance from the laboratory per se. So these were the 12 IMDs, 8 core and 4 secondary disorders that we finalized based on the Wilson-Jugner criteria, and other, things were also taken care of. So now we have 14 disorders that we are screening, 2 endocrinopathies, and the rest being IMDs. But remember, this is not a national newborn screening program. this could be my dream, but this is just a single institute newborn screening program story that I'm sharing. So we went from high risk screening to newborn screening. This is a, like I said, that we went for a phasic approach from congenital hypothyroidism to CH to IMDs. But also remember that we did this in reverse for IMDs. We did not have any data per se as a registry, but we did have screening data of high risk babies and adults who present with symptoms. So we had been doing urine organic acid and plasma amino acid for more than 13 years in the lab, and were able to screen in last 9 years around 40,000 adults and children, and out of which 3,000 came positive, giving around a positivity rate of 7%. So this evidence-based data approach helped us in convincing our leadership also. So a need was for newborn screening for IMDs was brought in discussion. Resource allocation, like I said, was done, and lab was fully prepared for implementing. And lab had been instrumental in providing data for medical teams wherever they needed it to convince, and also to other decision makers and policy makers. So once this was done, and newborn screening was implemented into 2023 for IMDs, we also started working on a proper database, like a data dictionary for rare registries, and it was established successfully in 2024, only recently. And now whenever we get a confirmed positive newborn screening patient or baby, he or she will automatically be linked to this registry. So with this registry, if you look upon it, we are currently, our focus was to examine what was available, but in the context of a registry, our goal is to uncover and find out things that are hidden from us. And so this is our dream, but let's see where it goes. So the registry has been looks promising, but it is only the beginning. And with this, I would like to end and reiterate that visionary leadership from my seniors specifically have been really helpful, but who you see here are the change agents. James also used the word change, so I would also like to emphasize that change agent, and any change is not easy. So everyone involved in newborn screening, I cannot take the names, but people know who I mean. So who I'm referring to, it's very important to be resilient and dedicated, and have that passion, that pioneering spirit if you want to bring a change. So from one analysis, one metabolite, one disease, I can proudly say we have now reached to one blood spot, one analysis, and many metabolites, many diseases, if not 50, 14, but still we are, in the right path. But the challenge of rarity remains. So this remains, and with this, I still have hope. And the biggest promise that this program has given, and we have the objective that if we have not received any confirmed positive for IMDs, correct me if I'm wrong, Dr. Aisha, but if we do get one, then we will be taken care of that baby, and we will ensure that the correct management and timely management is taken care of. Thank you very much.
Thank you, Lena, for taking us through your journey of initiating this program. And it is clear that to be effective, newborn screening needs to be delivered as part of a coordinated public health program designed to link sample collection, transport to testing, and results to effective treatment. And while international support is important, as James has mentioned, planning and delivery need to be firmly embedded in the country to ensure sustainability and ownership. It is hoped that the lessons learned will be an encouragement to others considering the introduction or development of newborn screening. So I will now ask all the speakers to come to open their cameras, and we can have James, are you there? We can take questions from the attendees. So there is one question. I think Hafsa, this one is for you. Zikora is asking what is the best site for sample correction on for DBS?
Okay, thank you, Dr. Aisha. So Zikora, for infants or less than 6 months infants, you can the best site is heel, lateral side of the heel, and for more than 6 months, you can more than 6 months infants and adults all from the ring finger.
Uh, okay. Now, Lena, this question is, I think you will be able to answer. Anita Motiani is asking, do you also do patient clinical monitoring?
Of course, we do. So I think they are asking question about the positive cases, right? Because
I think so.
newborn screening is generally done for healthy baby, whoever is born. Newborn screening is applied to that baby. So yes, we do monitor clinic. We do have a clear, very constructive, very developed questionnaire or clinical questionnaire available. And with every sample, we do fill that questionnaire and are in close liaison with the clinicians. But these are for positive clinical cases that come out positive for high risk, but not for newborn screening. For newborn screening, we do not collect data. But when there's a screen positive, then we do go back and look at the clinical details. And Hafsa has been doing it for congenital hypothyroidism. So, and we have specialists looking after every disorder in the lab. Yeah.
And
Can I
then
ask a
there should be clinical monitoring by the pediatrician as well. So are you and they are also in contact with you?
yes.
Okay, so there is a question by from Dr. Sonali Shah. Can we collect umbilical cord blood samples?
Hafsa? Yes, we can.
So the question is, can we collect umbilical cord blood samples for newborn screening? I believe.
So in some settings, yes, umbilical cord specimens are collected for the newborn screening. You just have to validate them for analysis, and since the most of the reference ranges available in the literature and provided by the vendors of the kit manufacturers, they are for the heel prick samples. So you may have to look for or establish your own reference ranges. So yes, a few newborn screening programs, like for example, in I think Malaysia, they use the umbilical cord specimen.
Okay. So
I
I
think
think it's the yes.
Sorry, Aisha, I was just going to comment. I think it may be worth adding that you can certainly look at cord blood samples for conditions like congenital hypothyroidism and sickle cell disease, and people have done that. It's not absolutely ideal, but certainly it's possible. I think for IMDs, it is not really, because of course the growing fetus is protected by placental transfer of metabolites. So if you used cord blood samples, you would miss a lot of cases, and we've trialed this in various places around the world. We've trialed it in the UK because, of course, it is attractive organisationally, but I think for IMDs it is more difficult. But I mean, Hafsa is absolutely right that in Africa and in other places where nothing else is perhaps easily available, then getting a sample from cord blood or very shortly after birth can be useful for congenital hypothyroidism and for sickle cell disease, but perhaps is not ideal for IMDs.
Yes, I agree with Dr. James. It's not ideal for IMDs, but if you are targeting hypothyroidism, and if you, I mean, especially in LMICs when the discharges are earlier. So I'm currently in Sheffield, and here I've seen the samples are collected at 5 days of birth, but they're collected in the community by the community health visitors. So in back home in our settings, the samples are collected by the nurses, and the parents, they want to get discharged within 24 hours.
Yeah.
So in those contexts, in those situations, it may be beneficial, but you have to as Dr. James said, you have to look at what you're screening for. It's not for IMDs, it's acceptable for TSH and sickle.
So, James, there's question from Gopi. Is there a value in screening pregnant females?
Well, yeah, it's often a question that's raised, and of course, for some conditions, prenatal screening is quite useful for conditions that we understand. I think in this general whole population screening, where we've not got a particular prescription of disease either in that individual or in that narrow community, then it's not a road that we need to consider if we want to look
All
at the
right.
newborn child.
All right. So, James, there's a question on Newborn Screening Academy. So, Bijay Mishra is asking about the Newborn Screening Academy. So, can you please shed some light on it?
Yes, I can. Well, this is an experiment, so we're going to learn from this one, and then hopefully develop this more in the future. But we're beginning this. I think the first meeting is on the 23rd of March in Luxembourg, so it's a little bit late now to register, unfortunately. But we've got just short, I think, of 20 registrants. And this is aimed at people brand new to newborn screening. And we'll be covering topics exactly as Hafs has mentioned, such as basic things like blood spot quality and the importance of the quality of the sample to getting the correct result. But it will be a one-day introduction. And we're going to run this hopefully in the future. We're going to experiment this time and see how successful it is. It's meant to be something which is not just taught, but provides an environment where people can discuss things and learn from one another and work in little groups to consider questions about how the best way to do things. But then we would hope to run it perhaps around the ISNS meetings that happen around the world as a kind of pre-meet for people to come. At the minute, we've got some very limited funds for travel scholarships within ISNS, but we're contacting commercial partners. And I think what we would like to do is to set up a fund that would enable the exchange of people to move from low and middle income countries for education, but also for travel and for mentorship. And I think that's one of the things perhaps we can work together on as IFCC, ISNS, not just IFCC, ISNS, but right across other organizations as well, to enable that community, worldwide community of newborn screening to develop. And we hope that the Academy is going to play a role in that.
All right. So we have this question from Daniel Mania from Nairobi Al-Han Hospital. So he's asking that in a country where there is no national newborn screening program, what role can private health facilities play, and is it feasible to have testing at individual sites? So I would like to hear your point of view, James, and maybe, Lena can comment.
Yes, I mean, the short answer is yes. I think the ideal that we're working towards is for a government-led initiative that offers newborn screening to all babies. But I think we live in the real world, and we know that there's a path to evolving that. And we know that in some low and middle income countries, then if there are private facilities, and you can probably tell me better than I know, Aisha, but certainly in India and other places in Southeast Asia, there are sometimes private birthing facilities that will take paying patients, but then organize on the back of that a citywide program for newborn screening, sometimes offered free of charge and sometimes offered on a paying basis. And people balance things with that, occasionally getting research funding to get things off the ground as well. So there's no single right answer, and there's no reason why privately funded facilities, often restricted to urban areas, should not lead the way. But of course, what we would seek to do is to be able to reach out into the whole population of asymptomatic babies. And I guess that's where involving governmental health policy planners right at the beginning initiative, even if it is in a private setup, they can see what's happening, see what the potential is, and then perhaps work from that to establish things more widely afield. That would be my view, but you're probably better placed to say the value of one
Dr.
versus the
Aisha
other.
can also respond to this. She has the experience of, involving public and having public-private partnership. But yes, the answer is yes. But you need to understand the limitations. But what we've been doing is we've been trying to contact policymakers, doing advocacy. But also, what we need to understand that Pakistan has its own challenges. So it depends where you are. So you cannot leave the newborn screening a positive baby on its own, because here the conditions are different from a developed one. So what we've done is that we do not charge patients directly. It's like a program. So it's like, it's we've provided newborn screening to the birth facility at our Khan only, not as a test. But yes, we've been educating, we've been trying to do capacity building and what we can to other hospitals and our peers in public setups. But I think Dr. Aisha also has experience of this and would maybe can add one or two lines on this. So it can be done, but you need to understand that it's a newborn screening program that we're offering, not a test.
Yeah, exactly. I think as what we have discussed so far, we need passionate people, even in public sector also. People who should take the ownership of the whole process. And you know that you can't screen a child and leave it without doing confirmatory testing. So it has to be a program. You can't do it as a test. So having a whole team of individual at an institution is a must. So individual institutions, yes, and and it is also important to have resource people there. So what I see that there is a facility available. But it is in a private sector, but then there are local availability of that sector, which can help other institutions in developing their program in capacity building, as Hafsa showed the VLE, a whole virtual learning environment for training of allied health professionals, midwives, and nurses, etc. So obviously, institutions who are interested and have people with passion who takes the ownership can do it at the same time. All right. So we have now this question from Anita Motiani from Rajkot, Ames Rajkot. So she is basically asking, do you do patient clinical monitoring also all throughout their stay in the hospital? So I can respond. I think there is a whole pediatric team. Metabolic physician is there, and the whenever there is a patient positive is reported, flag is a message is gone to the whole pediatric and ICU team, and so then they start their testing from. They take it onwards then. Okay, so we have. A question from Daniel Mania. Um, Sorry, not from Jeffrey Omuse. So he's asking about how did you go about optimizing your screen cutoff values for TSH and 17 OHP to ensure reduced false positives? So who's going to answer
Based on my
that
growing
question?
experience, Hafsa has a better, experience, but it was just, database that we did adjust our cutoffs both for TSH and 17 OHP, but it was with our growing experience and the feedback that we were getting, because you need to understand we do not want to miss any false positive, we do not want to miss any false negative. So Hafsa, would you like to add anything? So yes, we did adjust them.
Yes, we reviewed the literature. Initially we used the literature cutoff. I think we used the NHS cutoff, and then once we had analyzed almost 5,000 patients, we reviewed our data again, and we regularly review our data to see whether we are reporting, false positive, to monitor our false positive rate. Also, it's a monthly indicator for us as well, that we monitor the incidence of confirmed positive as well as the false positives. So we monitor this data on regular basis, and after once we have analyzed 50,000 pool, we will establish our own cutoffs.
All right. So we have this question from Professor Dr. Turgay Koskan. He wants to know about the criterias for a particular disease to be included in the screening program other than Wilson and Jugner criterias. For example, quality of life in case of cystic fibrosis. So, James,
Yes, it is tricky. I think the first thing to say is that the Wilson and Huguenot criteria have stood the test of time. Of course, these were originally written not for newborn screening, but for screening more generally back in 1968. So they've been with us almost 60 years. And most governments um, would tend to say that they would use the Wilson and Huguenot criteria or some version of it. And they're really sensible criteria. The difficulty comes, of course, in how you interpret those criteria. So I don't think we necessarily need more criteria, and I don't think we need to depart substantially from the Wilson-Huguenot criteria. But I think they may be viewed differently as our knowledge grows. And crucially, of course, it's not just about the criteria themselves, but what level of evidence do we need in order to introduce screening for a particular condition in a particular place. And these, I think, evidence is difficult. And this is a plea to ourselves and to our audience that one of the problems that health policymakers face is that there is often a lack of evidence of benefit. There's a lot of opinion, a lot of clinical opinion saying, yes, it would be good to identify children early. But in terms of long-term follow-up and real evidence that screening programs are worthwhile and make a difference are difficult to come by. So if you have that experience, then please publish it. It will be useful in making decisions. But of course, one of the other tests which is variably applied are cost effectiveness. And most countries will know of cost effectiveness, but not all necessarily use that in decision making. In the UK, and it's maybe because of that that we are screening rather fewer conditions than in many places, then we attempt to apply both evidence requirements and cost effectiveness requirements fairly rigorously. And that's not because we want to limit screening, but we are conscious that the goal of screening is to do more good than harm at reasonable cost in a balanced way. So if you're making decisions about newborn screening, then it's about achieving that evidence-based balance in policy. And that's fairly difficult to get. And coming back to the previous question about cutoff value, of course, when we begin to screen, we don't only identify the target condition, but we increase phenotypic heterogeneity. And the lower the cutoff values are, for instance, in IMDs, the greater degree of phenotypic heterogeneity that we'll see. And what we kind of know is that those babies with really high results that have the classical form of the disease, we can be fairly confident that they will benefit, and very often benefit strikingly, sometimes in terms of saving their lives. But when it comes to more mildly affected cases that can create something of an economic burden for countries, then we're less clear about that. So I think there's an interplay of both what you introduce and how you introduce it. And that's exactly why we need national policymakers taking an overview of this as a public health intervention and not just a test. I don't know whether that really answers the question.
Yes, I think so. So, just last question from Dr. Sonali Shah from Madishe Institute of Health Sciences. So, she wanted to ask about the cord blood sample, which was addressed earlier. And she's also asking, we miss sample collection and follow up. So, maybe, some strategy to address this, that how do we optimize the follow up? Yes, Lena.
Can I ask a question, Dr. Aisha, before we end? Just one quick question.
Yes.
So my question is to Hafsa. Hafsa, you discussed VLE. So is your course available for international students also? Is just a local course that is available for dried
No,
blood
it is.
spots?
Yes, it is available for both local and international students. so they can get enrolled in it. So I'll share it with Dr. Aisha, and she can share it with the ISNS team, so they can make it available for everyone.
So, with this, we would like to end our webinar. Thank you for attending, and thank you, Professor Bonham, Dr. Majid, and Dr. Jafri, for your interesting presentations that provided such valuable information on the topic we discussed. And of course, thanks to IFCC for offering this tool for e-learning. Please remember that if there are unanswered questions, they will be replied by email to those who pose the question. And the certificate of participation will be provided at the end of this webinar after a few questions. At the end of the questions, please click to show my scores at the end of the page and get your certificate. And to earn CE credit, participants must complete the activity online, and a passing score of 75% on the post-webinar quiz is required to receive 1.5 CE credits. And last, the on-demand content of this webinar will be available in short, and you will be informed via email. And lastly, there will soon other IFCC free webinars, and they will be announced via IFCC communication channels, emails, websites, and IFCC social media. So please stay in touch. And thank you, everyone, for coming. And do not forget to celebrate the Rare Disease Day tomorrow, which is on 28th February every year. And goodbye from now on.
Thank you and goodbye.
Thank you, everyone. Bye bye.